Hello all. Today's topic is inflammatory bowel disease and irritable bowel disease. Inflammatory bowel disease, it is a group of inflammatory disorder of gastrointestinal tract which affecting mainly a small intestine and colon. It can be a two main category of inflammatory bowel diseases like ulcerative colitis which affect mainly colon and rectum, and Crohn's disease, which affect both small and large intestine. Difference between both the types. In case of ulcerative colitis, it is involved only the colon and it's starting from the anal canal. The disease may remain restricted to the rectum and extended. It may extend up to proximally up to the cecum. So, in case of ulcerative colitis, mainly lower part is mainly involved, and the lesions which were there in the ulcerative colitis, those lesions we can see that they are mucosal lesions were there. While in case of Crohn's diseases, lesions are patchy lesions were there, and it can be transmural lesions were there. That means they involve deeper tissues of gastrointestinal tract. It may produce, due to that patchy lesions or transmural lesions, it may produces a various complications like perforation. It may leads to fistula, strictures. So there are so many complications which are associated with the Crohn's diseases. So it can be started from the mouth to a anal canal. At any level, there is a chance of development of patchy lesions in case of Crohn's diseases. Regarding the etiology of inflammatory bowel diseases, the main reason that it says that there are few reasons which are responsible for the development of inflammatory bowel diseases. One of them is due to genetic predisposition. This is one of the factors which may lead to development of IBD, or the main reason for the development of IBD is a defect in the immune regulatory system. If immune regulatory system is altered, there is a altered immune response were developed, and which may leads to development of IBD. And there are certain environmental triggers where there those triggers like bacteria, fungi, viruses, excessive use of non-steroidal inflammatory drugs, or any infection, all these are the triggers which may leads to development of defect in the immune regulatory system, and ultimately all these are able to produce a inflammatory bowel diseases. Regarding the pathophysiology of inflammatory bowel diseases, uh, due to environmental influence, the commensal organism, their composition might be altered, and this, as well as there is a, due to environmental influence, there is an increased permeability of tight junction. Normally the cells in a GI mucosa, they are tightly associated, but the permeability of that tight junction is increased, and it may increase uptake of microorganism inside a cell. Due to that, as well as there is a impaired mucinous layer, the layer which is, we can see that it which is a protective layer. If that layer is impaired, the permeability of organisms and other factors, they are influenced, they are increased. Due to that, inside a cell, all these organisms and other factors, they were considered as an antigen. Due to that, they can activate a immune system. So there is a stimulation of dendritic cells, there is a stimulation of macrophages. So all these immune cells, they are activated, and ultimately this result in a release of, there is a reaction were taken place, and ultimately they are able to release a various production of pro-inflammatory cytokines. It may includes INF, it may increase interleukin production, it may increase production of TNF, tumor necrosis factor. So all these pro-inflammatory uh, cytokines, they are released because of activation of immune cells. Ultimately, continuous activation of those release of pro-inflammatory mediators, ultimately there is a loss of immune tolerance to uncommon cell bacteria or any other triggers, and there is a development of inflammatory bowel diseases. Regarding the drugs which are used for a treatment of health, inflammatory bowel diseases, the major group which are used is 5-amino salicylic acid, which include sulfasalazine, mesalazine, olsalazine, balasalazide. Others are known as an immunosuppressant. One of them is glucocorticoids, includes prednisolone or hydrocortisone. Then immunosuppressants like methotrexate, cyclosporine, azathioprine, or anti-TNF alpha agent infliximab. So all these drugs were used for a treatment of inflammatory bowel diseases. So one by one, the first group 5-amino salicylic acid, and the congener is sulfasalazine. As all amino salicylic acid contain a 5-amino salicylic acid, so it contains 5-ASA, which this 5-ASA is bound by an azo bond. The bond is um, this bond is known as an azo bond. So it bound by a azo bond to a sulfapyridine. This sulfapyridine is known as an inert moiety. So, uh, once this 5-amino acid, which is bound with the sulfapyridine with the azo bond, this azo compound are least absorbed in the stomach and a small intestine. When they reach to a ileum and a colon, the colonic bacteria can split out the azo bond by the presence of azoreductase enzyme. So after splitting out this bond, there is a release of 5-amino salicylic acid and sulfapyridine. Both are released. That released sulfapyridine is absorbed and responsible for the adverse reaction. So sulfapyridine, which is attached, which is mainly responsible, absorbed and produce a various adverse drug reaction. While the released 5-ASA, which is this is mainly a active substance of sulfasalazine, so that release 5-ASA produce a topical anti-inflammatory action. So it can reduce inflammation uh, by inhibition of pro-inflammatory mediators like platelet activating factor, tumor necrosis factor alpha. All these pro-inflammatory factors, their action were reduced by sulfasalazine, and in a sulfasalazine active moiety is 5-ASA. So this is the major action which is associated with the sulfasalazine. It also produces some effect by inhibition of lipoxygenase and cyclooxygenase, and by this way they can also reduce the production of prostaglandin and leukotriene. They are also inflammatory mediators, and they are also responsible for inflammation. So the some action is also there on the prostaglandin and leukotriene production. Regarding the therapeutic uses of sulfasalazine, it is a first-line drug to induce as well as to maintain a remission in patients of ulcerative colitis. So it can induce and maintain. It induce remission means immediately it can recover this, give a symptomatic relief, as well as it can continuously maintain its effect. So for that, 5-ASA suppository or enema, these are the two major different dosage forms which were used in patients with ulcerative colitis, where It is mainly confined, ulcerative colitis is mainly when it is confined to a rectum and colon. At that time, sulfasalazine is given as a suppository or a enema. But if it is extended up to a proximal colon, then only enema or suppository is not sufficient. At that time, you have to administer the systemic steroid. Systemic or orally administered 5-aminosalicylic acid. This produces a more beneficial effect. Congener is mesalazine. It is a mesalazine is basically a name which is it is a generic name which is given to a 5-ASA. So this 5-ASA it it is also known as an mesalazine. It is formulated as an coated formulation, or it is also known as a delayed release preparation. So the coated formulation, which mainly delivered a 5-ASA to a distal and a small bowel and a colon. So it release its contain 5-ASA is mainly released because of delayed release preparation at later part of intestine where the action is desired. So like sulfasalazine, the primary use of mesalazine is uh, for preventing a relapses of ulcerative colitis, as well as it is also used along with the corticosteroid in case of severe ulcerative colitis. It is mainly used with the corticosteroid. So the major use of 5-aminosalicylic acid derivatives, they are mainly uses ulcerative colitis. They are not indicated for a treatment of Crohn's disease. Another congener is all-silazine. It consists of two molecule of 5-ASA which is bound by a azo bond. So two 5-ASA is there. Once they are released, it may having double the effect. So osalazine is poorly absorbed in the ileum, and the bone azo bond is splitted out in the colon, and which can produce release of 5-ASA locally. Two 5-ASA molecules were released, and it produced localized anti-inflammatory effect. Balasalazide, in which a 5-ASA is linked with a component which is known as an 4-amino-benzoyl P-alanine. This substance is an inert carrier for a 5-ASA. So, as like as a sulfasalazine, where the inert carrier is sulfapyridine, but when sulfapyridine in sulfasalazine is absorbed, it is responsible for a various adverse drug reaction. While there is no any adverse drug reactions associated with the 4-amino-benzyl P-alanine because it is least absorbed. So there is no any adverse drug reaction. The 5-C which is released in a colon, which is mainly produce a topical anti-inflammatory effect. So it is indicated as a safer alternative for a sulfasalazine, where uh, produce almost equivalent effect as like as a sulfasalazine without any adverse drug reaction profile. Now comes to an other group of drugs. They are mainly known as an immunosuppressant. Here we discussed only the role of this drug in inflammatory bowel diseases. We are not going in detail about those drugs because it can be taken at some other time when those systems are ongoing. So what is the role of those drugs specifically in inflammatory bowel diseases? Uh, First component is glucocorticoids. These are the, we can see that glucocorticoids are always known as a powerful anti-inflammatory drug, as well as it also having immunosuppressant effect. This effect are produced by various different way. uh, One of the way is as it induces synthesis of protein like lipoprotein, the protein which is mainly uh, which inhibit the formation of which inhibit the what we can say, it inhibit the phospholipase A2, which is mainly responsible for a role for a generation of prostaglandin and leukotriene. These are the inflammatory mediators. So the production of leukotriene and prostaglandin were suppressed in presence of glucocorticoid by synthesis of lipoprotein protein, which mainly suppress the phospholipase A2. So you have already know the inflammatory processes in case of non-steroidal anti-inflammatory drugs. So the role of glucocorticoid is just to suppress them. As well as glucocorticoids also decrease the production of cytokines. So they can suppress the other cytokines like interleukin 6, and all cytokines were suppressed with the use of glucocorticoids. So they are indicated mainly for a treatment of acute episodes of inflammatory bowel diseases, but not useful in maintenance therapy, because long-term use of steroid is not advisable. So they are only used for a acute episode. Once the remission is developed, then the patient may be switched over to an 5-amino salicylic acid derivatives. It basically control both the symptoms of ulcerative colitis as well as a Crohn's disease. The effect of glucocorticoids, if the person is the patient is steroid responsive patient, it can improve clinically, improve the symptoms free within a 1 to 2 weeks of therapy. And by the time person is remission free at once it is that level is achieved, gradually the steroids were tapered. While if person is steroid dependent patient is there, same recovery is achieved within a 1 to 2 weeks of therapy. But once you start withdrawing or once you start tapering the doses of glucocorticoids, that may leads to rebound effect. So in those cases, it may steroid dependent patient, they may require a low dose of steroids for a long period of time. So for acute prednisolone is a use for acute as well as a severe exacerbation of inflammatory bowel diseases, and for ulcerative colitis that are not responding to a sulfasalazine group of drugs, then uh, before starting a systemic steroid, start with a uh, localized preparation. Steroid retention enema were started along with the 5-ASA, so it may gives a better response. While moderate to severe attack of ulcerative colitis who are treated with the systemic glucocorticoids, they are administered by the oral route. Their anti-inflammatory uh, response appears within 2 weeks. Once the remission has been attained, the doses can be tapered. If there is a no improvement, if by using steroids still there is a no remission is developed, then it is necessary to add a uh, other immunosuppressant may be added, and once it to induce a remission, and once the remission is achieved, then person can be shifted to a salicylic or a sulfasalazine derivative, that for a maintenance therapy. Another group is immunosuppressant. These drugs mainly suppress the excess immune responses, so they are used for a long-term management of Crohn's disease. So this drug are mainly indicated for a treatment of Crohn's disease. The one of the congener is cyclosporine. The cyclosporine may induce a remission in case of severe ulcerative colitis who are not responsive to a corticosteroid. So then when the corticosteroids are ineffective, at that time immunosuppressant like cyclosporine may be started. So it causes a effect like suppression of pro-inflammatory mediators. So those mediators which are mainly responsible for the inflammation that can be suppressed by using cyclosporine. So for this, it is administered by the intravenous route of administration is given to achieve a remission. Once the remission is achieved, maintenance therapy with the azathioprine were administered. Azathioprine is it is also another immunosuppressant drug. This is azathioprine and 6-mercaptopurine. They both Azithromycin, as such, it is a prodrug which is converted to its active metabolite that is known as an 6-mercaptopurine. So both can be used as interchangeably. Both are get as such they are ineffective, but both get converted to their active metabolite, and these active metabolites having longer plasma half-life. So that conversion from inactive metabolite to an active metabolite, that conversion take time. As a result, due to that, the therapeutic effect of azathioprine is delayed by a 6 week. So for immediate recovery or immediate to start a remission, hence it is not effective for induction of remission in ulcerative colitis. So they are indicated for maintenance therapy. So they are indicated in case of steroid dependent or steroid resistant, as well as severe cases of inflammatory bowel diseases, both ulcerative colitis as well as Crohn's disease. Another group or another drug which is also known as an immunosuppressant, methotrexate. This is a dihydrofolate reductase inhibitor, so which can reduce the production of folate, as well as with immunosuppressant effect. It also produces an anti-inflammatory effect. Methotrexate mainly it is also known as an anti-cancer drug in various conditions. In case of inflammatory bowel diseases, the main action which is produced is suppress the immune system as well as produce a localized anti-inflammatory effect. So it is known as an it is used as a second line drug in case of uh, inflammatory bowel diseases. It may be needed in case of Crohn's disease, where it achieve a fast remission, and then azathioprine or other immunosuppressant drugs can be added for a maintenance therapy. And the last group is anti-TNF alpha agent. In case of inflammatory bowel diseases, tumor necrosis factors is an important pro-inflammatory cytokine, and to inhibit that cytokine, infliximab is a monoclonal antibody uh, of TNF. So, what that can do, infliximab that can make a cross link with the membrane bound TNF alpha receptor and inhibit the T cell and macrophages. So T cell and macrophages functions were suppressed in presence of anti TNF alpha agent. So due to that, the release of pro-inflammatory cytokines were prevented. So the release of interleukins and other pro-inflammatory mediators, their release are prevented. So they are mainly indicated in case of moderate to severe Crohn's disease as well as a ulcerative colitis who are not respond to an other drugs. So we can see that this drug as a monoclonal antibody of TNF is used as a last treatment option for any type ulcerative colitis or a Crohn's disease. So this is a therapy of inflammatory bowel diseases. Condition is irritable bowel disease syndrome. It is a common condition which is characterized by abnormal bowel function where there is no any specific organic cause is there. Person with irritable bowel diseases, abdominal pain which is mainly associated with a diarrhea or a constipation. The reason for the development of irritable bowel diseases, it may be uh, developed because of stress, lack of dietary fiber intake, due to food allergy, or due to any emotional disturbance. For a treatment of inflammatory bowel diseases, mainly the therapy is categorized in three different category. First, the pain is there, so first to relieve a pain. Second thing is that either it is diarrhea dominant or a constipation dominant. So on the basis of that, you have to administer treatment either for the diarrhea dominant irritable bowel syndrome, or we have to give a treatment for a constipation dominant uh, irritable or sorry irritable bowel syndrome. So, for a pain relief, drugs like tricyclic antidepressant like imipramine, this tricyclic antidepressant drugs, they are also having anticholinergic effect. So, this anticholinergic effect mainly helpful to reduce the GI motility, as well as they can also reduce the secretion. So that can helpful to uh, reduce the frequency of stool in case of irritable bowel syndrome. So one of the drug which is used is tricyclic antidepressant imipramine, or you all aware about the anticholinergic drugs like dicyclomine, or we can say that the antispasmodic drugs all are used to relieve a spasm by blocking a muscarinic receptor on a GI tract. So by by blocking a muscarinic receptor in a GI tract, they can relieve a spasm, and by this way they can get relief of pain, get relief from a pain. Then a treatment if it is a diarrhea dominant, in patient of diarrhea dominant irritable bowel syndrome, the drug which is used is loperamide. It is a preferred over the uh, it is basically a opioid analgesic drug. So it is preferred over other opioid antidiarrheal drugs because it having a less CNS side effect. So basically, loperamide is a drug of choice for a diarrhea dominant irritable bowel syndrome. And second one is allosterone, which is a selective 5-HT3 receptor antagonist. By blocking 5-HT3 receptor in a gut, it can reduce the intestinal motility and the pain impulses from the GIT. So it is 5-HT3 antagonist can also be used for a diarrhea dominant irritable bowel syndrome. So this allosterone is basically approved for a use in women who are having a irritable bowel syndrome with prominent diarrhea and which are not respond to an other drugs. So for that, allosterone is a preferred drug. And in case of constipation dominant irritable bowel syndrome, ticagrelor, it is a partial agonist for a 5-HT4 receptor which promote a gastric emptying. But the main drawback of ticagrelor is that it is it also having a risk of heart attack and stroke. So when it is used for that purpose, the cardiovascular side effects are associated. So it is now the use of testosterone is withdrawn from many countries for a use as an for a treatment of irritable bowel syndrome. And another congener is uh, guanylate cyclase C agonist, that is linaclotide. What this congener can do, it can reduce the activation of colonic sensory neuron, and it can reduce the pain, as well as it also activate the motor neuron in a intestinal tract, and it result in a chloride rich secretion. So chloride, if chloride rich secretion is there, so it is basically helpful to in case of constipation dominant irritable bowel syndrome. If GI secretion were increased, it can increase the, it can what we can say, the stool consistency where uh, liquefy, and it is used for a constipation dominant irritable bowel syndrome. Only drawback, this is a newer congener. Only drawback of this congener is that the cost is very higher. So this is a treatment of irritable bowel syndrome, either for a pain relief, treatment for a diarrhea dominant or constipation dominant therapy. So in a summary, we can see that if person having inflammatory bowel diseases, for a 5-aminosalicylic acid is the first line treatment for mild to moderate ulcerative colitis. If severity is higher, corticosteroids are used in a treatment of moderate to severe ulcerative colitis and Crohn's disease. So first choice is 5-SA. Then we can add a corticosteroid for both ulcerative colitis as well as a Crohn's disease. If it is ineffective, then we can add other immunosuppressant therapy. And for a treatment of irritable bowel syndrome, for a pain relief, antispasmodic drugs like dicyclomine or tricyclic antidepressant are used, along with, if it is a constipation dominant, drugs like tegaseroid or linaclotide are used, or if it is diarrhea dominant, we can use loperamide or allosterone. These are the drug of choice for a irritable bowel syndrome.